I think that the 2025 KDIGO guidelines are actually very accordingly moving with where the field is right now. So the two major acknowledgments are that we understand now that this is a disease that is not as benign as we previously thought, and that also for the first time in history, we have mechanism-driven therapeutics. So the guidelines are going and moving forward and recommending all physicians to stop the wait and watch approach for those patients in which we believe there can be a risk of progression, defining those as patients who have more than 0.5 grams of proteinuria and other risk features and that have high scores on prediction high scores on prediction risk tools, although we don't have quite understanding of what this really means. So you're asking me about what are the limitations of these guidelines. Well, the changes are, first, that we have to be more aggressive, right? And the second part is that we have to do simultaneous work for these patients, not only managing the IgA nephron loss that has already happened, but preventing new nephron loss from happening with these medications that now can target the disease itself. The problem is that we still don't know how to allocate all of these resources into individual patients. So that's one major concern from the public. First of all, it is very hard to do these guidelines, and I want to value all the work that went into this. And the guideline cannot answer these questions because we still don't have the data to answer these questions. But the field is rapidly evolving, and soon I'm pretty sure that we're going to see upcoming advances on these guidelines as well, showing us how to allocate all of these new resources into patients. The other thing is that some physicians still don't see a necessity to be so aggressive with patients that may not seem to be having present issues at the time of diagnosis. But we know now from registry data that the natural course of this disease is way more severe than we previously thought. There's a lot coming on in the horizon, and I think that now that treatment is out there, right, it is necessary to understand how to use them, as I mentioned before, how to combine them. And this is where real-world evidence actually comes into play. We have all the pharma research, we have all the mechanistic research. Now we have to see how to allocate the patients. And it's up to us in the community and as nephrologists to start using these medications and generate this data. Difficult things is trying to understand how to allocate all of these resources into specific patients. We also have not answered the questions of how are we going to use these resources in the future. It says we understand that these patients have been enrolled in trials for 1 or 2 years. What happens after discontinuation of therapy? Do we need to continue therapy indefinitely? Is this actually really truly disease modifying, or are we just controlling the disease process? All of these questions need to be answered. Now, moving forward in research, having available options actually limit our ability to do trials. It would not be ethical to actually have trials that are placebo-controlled. So we also have to redirect the way that we do trials to fit for those patients and to give them a fair treatment and not actually enrolling them into a placebo.